So Stephanie London is a member of our Cancer and Mental Health Stakeholder Board. She also participated in our trial, and she's going to just say a very brief.
Good morning.
Morning.
I was in the hospital recovering from cancer surgery when I learned about Dr. Irwin's pilot study. And I decided to participate because I thought, well, it can't really make things any worse. I didn't know you yet. The idea that all of my doctors, my therapists, my oncologists, and my ECT doctors would communicate and perhaps collaborate made sense to me. My participation in the study vastly broadened the effectiveness of my support system, and I could feel the support directly. As things became more complicated, as they always do, the ongoing attention to my mental health and acknowledgement of the overall importance of my mental health meant that I could be in my strongest state of mind to face the challenges that were before me. I felt like my team had my back, and it was my back, me, as a whole person, and not just a group of symptoms and conditions. When I was diagnosed with breast cancer, I had more than a dozen psychiatric hospitalizations in my history, but I didn't need one during the extreme stressors of cancer treatment. Now, 2 years later, I work with Dr. Irwin as part of the Cancer and Mental Health Collaborative Stakeholder Board. I truly believe that all people with SMI and cancer should be treated the way that I was. I was supported so that my voice could be heard at such a vulnerable time, and my caregivers' voices were listened to as well and respected. I'm just one example of how much of a difference this approach can make. Our next guest needs no introduction, but it is an honor for me to introduce Dr. Kelly.
Thank you so much, Stephanie. So important to hear those words, and that's why we're all here. And that's the truth. You know, everyone who is born, this is Susan Sontag. Remember back when cancer, there was so much stigma about cancer. She's writing about cancer here. Everyone who is born holds dual citizenship in the kingdom of the well and the kingdom of the sick. And although we all prefer to use only the good passport, sooner or later, each of us is obliged to identify ourselves as citizens of that other place. Whether that place be oncology or mental health, we are all experiencing that, and that's the spirit with which we come to this room today and why we care about advancing cancer care equity for all people, including those with mental illness. So here, you know, I think that as Kelly Grill said very beautifully, and many people I know will relate to in their own families, we're not very good at talking about mental illness. We call it all different things or don't talk about it at all. And as a result, brain illness is too often invisible and unspoken. And that's a problem because it perpetuates a mortality gap and stigma that's really causing a lot of preventable suffering. The second myth is, so is it uncommon? So no. People affected by mental illness die primarily from suicide and violence. I hear this at every talk I give. Isn't the leading cause of death violence or suicide? No, it's not. And then finally, one I'm hoping to refute today, and we'll have a good discussion about, can individuals with mental illness participate in clinical trials? So I would argue, yes, with support, with thought, absolutely, and hopefully we'll have a good discussion about that. So uncommon, no, not at all. It's common, and we can think about mental illness differently. You can say 1 in 4 people or 1 in 5 people have been affected by mental illness, but even if we just exclude to diagnosed serious mental illness, at a minimum, we're speaking about 10 million adults in the United States, over 2.5 million people with schizophrenia, over 6 million people with bipolar disorder. And I hope that it shocks you that 40% have no mental health treatment. Worldwide, that's 90%. But I can tell you that even in Boston, amongst the most resourced place in the world, there are many people who are not able to access mental health treatment. And you know, it's a challenge. So John F. Kennedy, inspiring, absolutely. I'm a big fan, read all his books growing up. And I love this quote, right? His sister, you know, was in an asylum. And he said, reliance on the cold mercy of custodial isolation will be supplanted by the open warmth of community concern and capability. That was the wish. That was why they closed all those inpatient hospitals, why we went from 12,000 state hospital beds in 1973 to 671 in 2015. That's why I have 22 beds at my hospital to hospitalize people. But if that's all you have is this warmth and this wish, it's not enough, because we didn't build the system. If you Google Cancer Center and you Google mental health clinic, this is what you see. And I hope that it shows you that lack of investment. I hope it reflects the stigma that people have been speaking about and the fragmentation, which makes it essential to think about bridging the gap. If we don't share a medical record or an earmail system or know someone, everything gets lost. And so we need to do that differently. So life expectancy of a woman in Massachusetts is 82. The life expectancy of a woman in Massachusetts treated by the Department of Mental Health, 52. 52, that's Massachusetts, that's 30 years. My kids will be in high school. We need to do better. What are people dying from? The number one cause of death is cardiovascular disease. The number two cause of death is cancer. And as we've heard already from the commissioner, people are experiencing significantly increased cancer mortality from lung cancer, breast cancer, head and neck cancer. Why? Well, I'm an interventionist. I'm a health services researcher. I like to investigate things, develop solutions with them. I'm also someone who engages the community, but I want to break it apart, and I want something we can target. I don't want to feel like it's such a huge problem that I feel like I can't do anything. That's a rotten way to feel. So I want you to know that there are targetable things, that part of that disparity is driven by inequities in treatment received. That means that people get diagnosed later, so if they got lung cancer screening a different way, it could help. It means that people are less likely to get recommended chemotherapy or radiation or surgery at the time they're diagnosed, and less likely to accept that recommendation, and less likely to complete that treatment. It also means that at the end of life, people have less access to palliative care. They're more likely to die alone in a nursing home. They're less likely to be offered a hospice. And I think that that is something that we can do something about. So I saw Henry and Joan walk in. So I think that Jonathan Archibald taught me a lot about how to build a model by starting with where people are. I just want to throw out there that that's kind of the paradigm. When you have a person who's experiencing mental illness and cancer, and they have a lot of complex needs all at the same time, it's completely unreasonable to tell that person when they're so scared to go see a psychiatrist out there in the community. Get there. It didn't happen, and it was too much for him to come to our clinic. Didn't come 3 times. We had to come to him. But then when we did, everything changed. And he didn't trust me at first, and he tried to fire me multiple times. But I built a relationship with Joan, his mom, and he trusted his mom. And with that combined effort, we were able to get him through cancer treatment and help his mental illness be well controlled enough that we could understand his preferences at the end of life, which is something that's critically important for him and for his family. Not everybody has access to a family like the Archibalds. So this is the bridge I walk by from the North Station, the train station I go through. A lot of people who are homeless live under this bridge. It is there just to, also it's called This Neighborhood, This Side of Heaven, Best Neighborhood, This Side of Heaven. For me, that's a lot to stomach on my way into work, but it motivates me. And it reminds me of the people who don't have the Archibalds as their family members and who rely on us as a community. And one of those people, I randomly heard about, and that's why our program started. I started to get 20 to 30 referrals from nurses who didn't know what to do. And this was just one person like that who had lived, with schizophrenia for 20 years, was in a group home, and then got diagnosed with lung cancer and was so scared that she fled across town, didn't know what to do, and got sicker and wouldn't go to the hospital. And what can the nurse do? So that was kind of the question. So I want to acknowledge the fact that this isn't easy work. It's complex. It takes creativity. And we did qualitative interviews with oncologists and mental health clinicians about some of the barriers and facilitators to cancer care for people with schizophrenia. And this is what a medical oncologist says. Sometimes there's a groan that's uttered when you're taking care of a patient with schizophrenia. I imagine that lack of enthusiasm translates into poorer care. And I think that's a tough quote to read and here for people. However, I think it's a really important one, because I think that it's not, quote, yes, it's about attitudes toward people, but it's also about the fact that it's very difficult to do something where you don't have a healthcare system built around you to help you do it right. So it does take more time, it takes coordination, it takes collaboration, it takes support. And I just think that we need to kind of acknowledge the piece of, like, if we were able to be more helpful, it would be better. And then for the focus of this, I just wanted to make clear that right now, individuals with serious mental illness or mental illness at all are excluded from 50% of clinical trials. So that's, the paper published on this says this, and then this week I just thought maybe I'd check out clinicaltrials.gov. And I'd maybe just do a little thought experiment. And so I did. I went to clinicaltrials.gov and I said, what state? I'm gonna choose Texas. I'm gonna choose lung cancer clinical trials. And the same percentage came out, that about 50% of those trials excluded people with mental illness. And sometimes those were broad, if the person has a psychiatric disorder. More rarely, there were specific criteria that were related to the treatment that was given. So I just want to emphasize that the majority of the mortality gap that people with serious mental illness experience is driven by deaths from cancer and cardiovascular disease, and that we can do something about that by promoting equity in cancer care and other medical care for people. And that if we think differently about participation in research, I believe that people can and have participated in our clinical trial. So what have we done? So we developed a collaborative care intervention based on the principles of collaborative care, but uniquely tailored to the needs of serious mental illness, with a lot of mindful thought about how to connect with the community. And many of you in this room are from community mental health. And so are part of that dialogue, people who are in group homes, who are nurses, who are from the Department of Mental Health. We conducted a pilot study that demonstrated feasibility. And we are currently leading a randomized clinical trial examining the impact of this bridge intervention on cancer care. So our primary outcome is cancer care delivered, proportion of recommended cancer care delivered. So it's a little bit different than the usual cancer care, the collaborative care framework. And then finally, like we're doing here today, we're building partnerships that can broaden the work. So when we think about looking at a group of people, in this case, this is a group of 100 women with schizophrenia and breast cancer. 1 in 2 of them didn't get the care that they should have gotten. And that's at Dana-Farber and Mass General. That's horrible. But what was the #1 predictor of who did get the care? Whether or not they had a psychiatrist diagnosis and whether or not they were on antipsychotic medication. That's something we can target, so it's good. So this is our model. At the time of cancer diagnosis, well, first, for thinking about our population, we're going to be building a registry so that we know when people with serious mental illness and cancer hit our cancer center. We're also actively screening new oncology consultations and have developed relationships with the community and with the oncology team so that people know to refer to our team. And then we also engage the patient and their caregiver, whether it be a family member or person in the community. And they come together with the psychiatrist at the time of cancer diagnosis and have a joint consultation. We understand the person's values, their reasons for wanting or not wanting treatment. We address any psychiatric issues that might be barriers to care. We think about the social determinants of health. We help the oncologist think together about what the cancer care trajectory is going to look like, and we can do things that are creative. Like say, hey, maybe we'll give radiation on a different schedule, has equal efficacy. Let's think about that together. We can do that when we come together proactively. And then we link to a social work case manager, who is Amy in this case, who partners with the patient to understand their values and decrease barriers to care, and also do all that hard work of communicating with all of the people in the community that could be supports for this person. And then hopefully with this person-centered model, which involves going to the person where they are, so going to the shelter or to their home or to the hospital or to infusion, hopefully with this kind of an approach and a rigorous-based framework for our RCT, it will have the potential to really meaningfully improve cancer outcomes. So this is who we included. So individuals with schizophrenia, bipolar disorder, major depressive disorder with prior hospitalization. I run a schizophrenia program, and I can tell you these were amongst the most ill patients I have treated in my career, who were newly diagnosed within 8 weeks of initial oncology consultation, who were able to complete self-report measures. That was it. They could have comorbid substance use. So it was really intended to be very generalizable. And we tracked psychiatric symptoms. We tracked completion of cancer care. We tracked, and really, of course, the primary outcome here was feasibility. Would we be able to enroll these patients rapidly? Many people told me no. Would they consent to the trial, or would their guardians consent, and would they complete the trial? To do this work, it was really important to think about enrollment differently. We had to actually go out into the community and forge partnerships with the community. This wasn't a problem for us because I was getting referred plenty of patients all the time who were perfect for our trial. But that happened because we had meaningful partnerships with community mental health and with oncology teams who trusted us. And we systematically screened. One in isolation isn't enough. And then we thought very mindfully about the informed consent process. And we said, how can we actually help people to understand? Because a 13-page written document is much more about legal protection than it is about actually facilitating understanding of what's happening in a clinical trial. And I felt understanding that not everyone, but many people with psychotic disorders have cognitive deficits, they're thinking concretely, that it would make more sense to break things up in small pieces, to use concrete language, and to have a clinician have a conversation with the person. And maybe they might have to have a conversation more than once to build understanding. And with that procedure, we're able to do a really good job of getting people to be able to provide informed consent. So, was it feasible? So our goal was to enroll to our collaborative care trial in 15 months. And we enrolled 30 patients in 4 months. Our goal was that 50% of the people that we approached would consent to the trial. 88% consented, or their guardians did. Our hope was that 75% of the people would complete their assessment, 100% had their diagnostic assessment, and as you see there, 88% completed all the self-report measures. So I really believe it was feasible to do the study. Also, it was helpful. It was helpful to all the stakeholders who are important to think about, to patients, to caregivers, and to oncology clinicians who spoke meaningfully about how this intervention impacted cancer care, and specifically made it possible for patients who had not received cancer treatment to receive it. So 6 of the patients who enrolled in our trial had either had 1 month to 18-month delays or just simply not been offered guideline concordant cancer care in the community. All 6 received more cancer care than they would have, and 5 completed absolutely everything. Sometimes people tell me, well, did the patients really want that? Did they worry about being coerced? I mean, I showed you that picture of that wall, right, of the bridge across heaven, because I wanted you to think about what we did for that patient who was acutely disorganized and didn't understand what it was like to have lung cancer. That patient needed to come to the emergency room. And so that's what we needed to do, a mandatory evaluation in the emergency room. And once she got here, and our oncologist is here, where she enrolled in our clinical trial, consented to it. She got chemotherapy, she got radiation. She mostly quit smoking, not completely, but made some good progress. And none of those things would have been possible if we hadn't been thinking differently about clinical trial eligibility. And then we asked her, what did you think? And she said, you made me feel like I mattered, like I had a choice. Isn't that ironic that I'm the one who sectioned her to the emergency room? But really what we're doing is giving people the opportunity to make a choice. And I know we're over time, so I'm just going to very briefly state our next steps, which are we're currently doing a randomized trial to follow up on our pilot study. Like Kelly said, we actually have a much more robust caregiver arm where we actually engage caregivers and track caregiver outcomes. And we've actually worked very thoughtfully with our oncology groups to develop metrics for each disease center about what would be guideline concordant care and what actually constitutes a disruption, in addition to tracking things like proportion of radiation and chemotherapy received. It's complicated, of course, but for us, our primary outcome is, do you get through cancer care? We also care about psychiatric symptoms and quality of life, but we came to this as our primary outcome. So I hope we'll learn much more in this pilot RCT, and then also be able to identify barriers and facilitators to implementing and disseminating the intervention in the community with all of you. I think that's really what's been most exciting, is seeing these new research opportunities happen. People are screening in the community, they're calling me, there's initiatives in New York and here. So I think that's really, really important, and I think that's because it's not just us anymore, it's a collaborative. So this is the Department of Mental Health, it's NAMI Massachusetts, it's Mass General, the Mood Network, and Beacon Health Options, all coming together to change the paradigm on how we can actually increase access to patient-centered research for people with serious mental illness and cancer. So thank you very much.